Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 340 of our pharmacotherapy series, which majors in drug interaction. The first question reads, DTB is a 67-year-old Caucasian male who began taking imatinib about 10 years ago to treat a rare sarcoma, partially resected gastrointestinal stromal tumor, abbreviated as GIST. DTB currently takes 600 mg imatinib daily, as well as rabeprazole and furosemide. He states that he is currently not taking any non-prescription medications. He continues to go to the Cancer Treatment Center for continued monitoring. He contacts the cancer clinic to let them know that in 4 weeks he will be traveling to Africa to go on a safari. He mentioned that the friends that he will be traveling with told him that he will need malaria prophylaxis. You are consulted regarding this request as the medical team wants to know whether there are any potential drug interactions and which antimalarial agent would be an appropriate selection. Imatinib mesylate belongs to a class of drugs known as selective tyrosine kinase inhibitors, abbreviated as TKIs. It inhibits the BCR-ABL tyrosine kinase, the constitutive abnormal tyrosine kinase created by the Philadelphia chromosome abnormality in chronic myeloid proteins. It also inhibits the tyrosine kinase for platelet-derived growth factor, abbreviated as PDGF, and c-KIT. Tyrosine kinase inhibitors, such as imatinib, are extensively metabolized via cytochrome P450 enzymes, with a large degree of inter-individual variability. Imatinib is metabolized primarily by CYP3A4, whereas CYP1A2, CYP2C9, CYP2C19, CYP2D6, and CYP3A5 are reported to have a minor role in its metabolism. In addition, imatinib is a substrate of human organic cation transporter type 1, abbreviated as H, OCT1, P-glycoprotein, and BCRP, though it is unclear whether imatinib is a substrate or inhibitor of BCRP. Imatinib also competitively inhibits the metabolism of drugs that are CYP2C9, CYP2C19, CYP2D6, and CYP3A4 substrates. It is also highly protein-bound, with approximately 95% bound to human plasma proteins. Let's discuss drug-drug interaction, with an emphasis on pharmacokinetics, paying attention to drug metabolism or elimination. There are several considerations of potential drug interactions with imatinib. Drug interactions should be considered when imatinib is administered with other agents in the CYP3A family. In particular, Interactions are likely with inhibitors of CYP3A4, such as voriconazole or amiodarone, resulting in increases in the plasma concentration of imatinib. Concomitant use of rifampicin or other strong CYP3A4 inducers with imatinib should be avoided. In addition, concomitant administration of imatinib with agents that are both inhibitors of CYP3A4 and P-glycoprotein increases plasma and intracellular imatinib concentrations. Examples of dual CYP3A4 and P-glycoprotein inhibitors include verapamil, erythromycin, clarithromycin, ketoconazole, fluconazole, and itraconazole. Tyrosine kinase inhibitors, such as imatinib, also can inhibit drug transporters and enzymes, resulting in changes in the exposure of co-administered drugs. St. John's wort significantly altered the pharmacokinetic profile of imatinib with reductions of 30% in the medium area under the concentration time curve, abbreviated as AUC. Patients should be cautioned regarding the concomitant use of products, such as St. John's wort, as well as other inducers, that may necessitate an increase in imatinib dosing to maintain therapeutic efficacy. Drug interactions involving protein binding of imatinib and other highly protein-bound drugs are not well understood. A study published in 2016 examined drug-drug interactions observed in patients treated with imatinib. The investigators performed 2 observational studies to identify the medications that were most frequently dispensed simultaneously with imatinib through the French Health Insurance Reimbursement Database SNIRAM, an abbreviation for Système National d'Information Inter Régimes Assurance Maladie, as well as the ADRs related to drug-drug interactions involving imatinib using the French Pharmacovigilance database. A sample of 544 patients from SNIRAM with at least one reimbursement for imatinib were identified between January 2012 through August 2015. Of this cohort of 544 patients, 89.3%, 486, of patients had at least one prescription medication that could potentially interact with imatinib based on mechanism of action, e.g., metabolism pathways. The results of the study also found that the most frequent drug-drug interaction was with paracetamol, that is acetaminophen, that is 77.4%, which resulted in an increased risk of paracetamol toxicity. Other study findings with greater than 10% of patients with potential drug-drug interactions were with proton pumps inhibitors, that is 33.3% for omeprazole, or dexamethasone, that is 23.7%, that could reduce imatinib's effectiveness, and with levothyroxine, that is 18.5%, that could decrease levothyroxine's effectiveness. The suspected mechanisms of this drug interaction with levothyroxine are an induction by imatinib of non-deiodination clearance or induction by imatinib of uridine diphosphate glucuronal transferases. Study results also found that the most frequently used drugs that could increase imatinib toxicity were ketoconazole and clarithromycin, respectively, 5.1% and 4.7%. The overall findings of this study suggest that at least 40% of patients who are receiving imatinib are at risk of drug-drug interactions and may reach an even higher rate according to the results of the study performed in SNIRAM. The highest rate of potential drug-drug interactions in this study with imatinib was with the following agents: paracetamol, proton pump inhibitors, dexamethasone, or levothyroxine. Based on the study findings, the investigators provided recommendations regarding the use of imatinib with specific agents. It is recommended that the reader refers to the package insert of imatinib for drug interactions and dosing guidelines. Further study regarding drug-drug interactions with imatinib, as well as other tyrosine kinases, is warranted. With regard to selection of an antimalarial agent for DTB, chloroquine, mefloquine, and atovaquone proguanil, marketed as Malarin, may have potential interactions with imatinib. The proguanil component is metabolized via the 2C19 pathway. Given the options that can be used for malaria prophylaxis in DTB, doxycycline would be an appropriate antimalarial agent used for malaria prophylaxis that does not interact with imatinib or DTB's other medications. The most commonly reported adverse effects with doxycycline are GI effects, including nausea, vomiting, abdominal pain, and diarrhea. Esophageal ulceration associated with doxycycline is a rare but well-described adverse event. DTB should be counseled to take doxycycline with food and plentiful fluids, in an upright position in order to minimize GI adverse effects. Because doxycycline can cause photosensitivity and DTB will be on a safari, the risk of photosensitivity can be reduced by the use of an appropriate sunscreen and wearing protective clothing, including a hat. DTB should also be counseled regarding the use of paracetamol, acetaminophen, and also to check in advance with his pharmacist before taking any natural products that may be metabolized via cytochrome P450. Let's now look at resources and evidence for clinical decision support. Healthcare providers have become increasingly challenged on devising optimal approaches to managing drug interactions. Patient safety initiatives have expanded in efforts to improve the healthcare delivery system, with medication error prevention as a high priority area. The consensus recommendations published by the expert group in 2015 have provided a roadmap for addressing the key concerns to improve the approach to evaluating drug-drug interaction evidence for clinical decision-making. As part of this process, it was important to review existing methods for evaluating drug-drug interactions. The Drug Interaction Probability Scale, abbreviated as DIPS, a 10-item scale, was developed to evaluate individual case reports for drug-drug interactions by assessing an adverse event for causality by a drug-drug interaction. This tool was developed to address limitations of previous assessment instruments, such as the Naranjo scale. The reader is referred to Appendix C of the consensus recommendations for further information regarding drug interaction probability scale and other available instruments. The expert group also discussed the current systematic approaches using clinical decision support (CDS) systems, their limitations, and the need for a new assessment instrument to objectively evaluate a body of evidence to establish the existence of a drug-drug interaction. One of the key challenges of clinical decision support systems is to determine what evidence is required for a drug-drug interaction to be applicable to an entire drug class. Pharmacokinetic interactions are rarely generalizable to all agents within a drug class, and if there is class effect, the magnitude of the effect can often vary, which typically necessitates that each drug is reviewed individually. In some cases, pharmacokinetic interaction data may be extrapolated from one agent to other agents in the small class if the purported mechanism of interaction involves common pharmacologic effects. To advance this important initiative, recently another group of experts convened to address the following. 1. To outline the process to use for developing and maintain a standard set of drug-drug interactions. 2. To determine the information that should be included in a knowledge base of standard drug-drug interactions. 3. To determine whether a list of contraindicated drug pairs can or should be established. And 4. To determine how to more intelligently filter drug-drug interaction alerts. Their recommendations for selecting drug-drug interactions for CDS were released in 2016. The reader is referred to both the 2015 and the 2016 recommendations. Because various avenues are examined to reduce the risk of drug interactions within society, it is essential as healthcare providers that we improve patient education regarding medication information. This strategy includes our communications with patients, both verbal instructions and patient instruction leaflets given with the prescription. It is important to consider translation of information into different languages and to also promote culturally competent communication within every healthcare setting. The use of auxiliary warning labels placed on the medication package, books, and referring patients to quality health information on the Internet. Pharmacists are uniquely positioned to provide important information regarding OTC medications, including herbal products when patients receive prescription information, and when they are seeking recommendations for OTC products. Given the complexities of data on drug interactions and the complexities within the healthcare systems, healthcare providers have become increasingly challenged on devising optimal approaches to managing drug interactions. Patient safety initiatives have expanded in efforts to improve the healthcare delivery system, with medication error prevention as a high priority area. Medication errors may be related to professional practice, healthcare products, procedures, and systems, including prescribing, order communication, product labeling, packaging, nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. Because exposure to drug-drug interactions is a significant source of preventable drug-related harm, appropriate medication use, including drug interaction management, will avoid medication errors. Although the majority of drug interactions are clinically insignificant, in certain circumstances drug interactions are considered to be highly significant and can cause harm. Patients should be informed of the importance of maintaining a complete medication profile, including over-the-counter medications, herbs, and dietary supplements. The incorporation of pharmacogenetic information into risk assessment of patients will improve our ability to prevent drug-drug interactions and to better evaluate interactions with biologic drugs. More well-controlled studies are needed after drug approvals. Population-based studies are useful to determine the severity of, incidence of, and clinical importance of drug interactions. Pharmacogenetic research can further improve the precision of DDE evidence and CDS by identifying patient-specific predisposing factors. Future directives will identify the most appropriate process to rate the quality of drug-drug interaction evidence and provided graded recommendations to reduce the risk of adverse consequences. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 341.